If you ever watch hospital dramas on TV, you know just about like every second or third character who shows up to Gray Sloan Memorial, they seem to need CPR.
He coded in the elevator.
One, two, three. All right, let's get him back.
I'm some more blood. Paddle. Push me up with bicarb. Clear. We have sinus.
Another life is saved. No overcrowded waiting areas. No one downplaying symptoms. No one implying you're a drug seeker. No one maybe ignoring you for hours on end. Dr. Holly Graham knows what real-life hospitals in the US and Canada look like. She's a Cree-registered nurse who has spent more than 40 years caring for patients. She believes in relational relationships, reconciliation, and reclaiming identity. And she knows we all believe in CPR, in cardiopulmonary resuscitation. We know CPR saves lives. It's not just on Grey's Anatomy. Well, Holly Graham created CPR for racism, and she's our guest today on Researchers Under the Scope. Hi, I'm your host, Jen Cannell, and we are recording this on lucky Friday the 13th of March, 2026. We have ironed out a whole bunch of technical glitches to bring you this podcast. And our guest today is Holly Graham. Now, she is a Cree professor at the University of Saskatchewan College of Medicine's Department of Psychiatry. She's also a registered doctoral psychologist. She holds an Indigenous research chair in nursing. And yes, she has watched a few episodes of Grey's Anatomy. Dr. Holly Graham, welcome to Researchers Under the Scope.
Thank you for the invitation, Jen.
One of the things that I was kind of curious about when we say that you believe in relational relationships, it's like, what does that mean?
Well, it's looking at relationships that are built on trust and empathy and emotional investment versus just like a transactional type of interaction. So it really looks at long-term mutual care and understanding long-term over short-term gains.
Which if I think about the way our hospital's set up, they used to be very transactional. You'd come in, your arm is broken, your leg is broken, we'll fix you up, pay the money, off you go. But that doesn't necessarily serve us in today's day and age. And I'm looking at your career. You've spent more than 40 years caring for patients. How did this all start for you?
Well, to be honest, it was never my dream. It was my mother's.
What?
She was a CNA for 23 years, and it was a certified nursing assistant. And she just said, I want one of my daughters to be a registered nurse because she had worked in healthcare. And I was the oldest. And I wanted to go in to be a police officer, an RCMP officer. And then I'd wanted to pursue law and move on to be a judge. That was my dream. But I was really young when I graduated from grade 12, and she said, Holly, you should just go into nursing. Just go do a 2-year diploma. Then you'll be old enough to get into the RCMP, and then you can change directions. So ironically, it was my mother's dream. But she was very wise because health is wealth. And that's what I've come to know and what I come to share. And health really is wealth.
You obviously didn't want to quit after a couple of years. Is there anything that kind of stuck with you from those very early days in your career?
Well, I was the only one who was from a reserve, attending school at that time. And there was over 200 of us registered. Back then it was Kelsey Institute of Applied Arts and Sciences. So there was no one like me in terms of having similar experiences or background or had grown up in anything that was similar to what I grew up. So I think that when I graduated in 1985, it was incredibly rare to run into another First Nation nurse. And that's part of the reason, that loneliness and recognizing that we needed more, because if we really wanted to address the health disparities, we need a representative workforce. So one of the priorities that I had was, how do I build in mentorship? My chair, when I was awarded, I wanted to focus on mentorship and reconciliation. And mentorship, looking at how would we provide that in an institution such as a university. And what I decided was address it from 2 points. Yes, definitely within the institution looking at changes, but also I created the Indigenous Professional Practice Group, which is a part of the regulatory board, the College of Registered Nurses of Saskatchewan. And so that provides mentorship to nurses who are still undergraduate and practicing nurses. So that was part of, in response, I think, to feeling lonely, isolated, and wanting to just to create a wave of support, because that's what it feels like. It feels like this constantly moving, dynamic relationship that I have with these nurses who are in the PPG, and where we can share experiences and of course, looking at solutions like how do we move forward in a good way.
Well, and you could have had a very long and successful career just being a nurse, but you decided to go back. And I'm wondering, where was the TSN turning point that kind of pointed you more towards the academic and research worlds?
Well, I've been nursing for about 20 years, and I didn't understand the health disparities, like where they originated from. I knew they existed, I could see them. Nursing, I started my career in nursing in the north with medical services, but I didn't understand why we had these health disparities. Why were First Nations people tending to be more poor and all those determinants that we know? And so I thought, I need to go back to school. I need to learn and see, because even though my family and my mother was in attended a residential schools, attended day school as well, they never talked about it. And so it's not like I had inside knowledge. I was living the consequences of it, but I had no understanding of how my life had been impacted, and certainly no understanding of how my mother and my family had been impacted. So when I came back to university to do my master's, I focused on Indigenous health, and I did the same thing for my PhD.
What kept pushing you through that time? Because that's not an easy life turn.
Well, it was the desire to look at what are the roots of the health disparities, and how could I make a difference, because I could see that the suffering was continuing, it was ongoing, it was daily. And I was seeing the increased incidence of mental health, like suicide, and the chronicity of conditions that are related to cardiovascular, endocrine, like diabetes. And I just thought there has to be something that could start and could be effective to start addressing this. And and that was really the impetus. It was to gain, for me myself, to gain a better understanding of looking at this from a broader lens, a different lens, and a lens that had been informed by what we knew about health, what we know. And when I graduated, social determinants of health was not something in 1985 that was talked about. There was that thinking of, if we make poor choices, we're going to have poor health. And if we make good choices, then we're going to have good health. It was really about individual responsibility for the condition of our health. There wasn't that understanding of the social context, which there certainly is now, because that has changed.
Well, and as you're going through and getting your master's, writing your PhD, were you still working through that time? Were you still in hospital settings?
For my master's, when I was doing that, I was casual at City Hospital, working day surgery. And then when I was doing my PhD, I had to make a choice between staying in a clinical setting or moving to actually, I guess, build capacity as a psychologist. And so when I was doing my PhD, I worked 2 days a week at Adult Community Mental Health, which is a part of the SHA, Saskatchewan Health Authority, and then started providing mental health services then.
Oh, okay. And do you still provide mental health services?
I do. I have a private practice that I run on Saturdays, and I specialize with working with individuals who've experienced trauma and have symptoms of PTSD.
Oh, wow. Well, I looked back and you've written dozens and dozens of academic publications. You've got hundreds of people citing your work and citing your findings. And you've also put together so many like learning guides and videos. You mentioned the working group for like the professional practice group for nurses, pamphlets that you've put together. And I don't see you charging a whole lot of money for this stuff. Why not?
Oh, it's all free. I believe in my role, and I'm in a role of privilege, being a professor at the University of Saskatchewan, and that privilege is, we have the opportunity to stretch epistemology, to look at other knowledge systems. We have the capacity to do research, to bring new insights, new pathways towards health and wellness, and we have a chance to explore. But we also have a chance to be creative and innovative with knowledge mobilization. And that's one area I've really focused on, is how do I get this knowledge out there? How do I start creating a wave of awareness, which hopefully will go to change? And so that's why I thought about this professional practice group within the CRNS, so that we have this direct platform of communication. So there's a new anti-racism guide in nursing that was developed initially by the CRNS in response to now TRC Call 24 being required for accreditation with COSN. It's the Canadian Association of Schools of Nursing, and they set the standards for accreditation. And so the 6 chairs, we lobbied and had meetings with them, and that was actually successful and now integrated. So nursing has really changed, and I'm so pleased and I'm just thrilled at the changes that have been made as a result of that. And so that really was my goal, is how do we create this culture of caring that is more informed? I believe all nurses and healthcare providers come into the discipline because they care about people, right? But there's something that happens before they come in or during the process that I think it's just that we're not necessarily, and I know from my own nursing education, I wasn't best prepared to even work with my own relatives to have this information. So I've started the professional practice group, and we have our own clothing. And many of the nurses will wear them when they're working in corrections or they're working community health to proudly display nurse, Muskegeenawak, Muskegeesquo, medicine woman. And it's just been really important to me that we create this culture of awareness first and understanding, but then pathways. How do we move forward?
I know in the introduction, we heard a little bit of Grey's Anatomy, like probably one of the most watched, besides ER, one of the most watched series that takes place in a fictitious hospital ever. How much, how much Grey's Anatomy have you sort of ingested and then gone, oh, okay, and then there's real life? Like, how does the show work for you?
I just enjoyed it because I don't know, as it is, I enjoy the excitement. I enjoy, being the detective, figuring out what's going on. It just so happened when Joyce Echaquan unfortunately had that tragic ending that she had to her life here on Earth
In Quebec.
in Quebec. Yes, I just thought, what can I do as one nurse? And I prayed about it, and that is a part of who I am in my life. And I said, I don't know what to do, but I'm open to whatever it is. And then I was watching Grey's Anatomy and just remarking how CPR is just given, so frequently. And it's such an important part of saving lives and resuscitating people, and such a gift that so many people have been trained in this. And it just struck me, I need to write CPR racism to begin to start to address access, like how people are treated when they enter into healthcare facilities. And so it just hit me because little Meredith, all 90 pounds of her soaking wet is, jumping on the gurneys and doing CPR. And I picked CPR because it underscores the urgency of life. We know CPR is life-saving. And so I picked it CPR racism to underscore that people are unfortunately not having the best health outcomes and in some situations dying as a result of racism. So that was how that came together. It was just kind of, I put it out there, prayed, and then when I was watching Grey's Anatomy, just boom. And that's sometimes how things happen when I move forward with a research idea or in any aspect of my professional career.
One of the things that I've noticed is that in terms of bridging some of these gaps in plain English, you said, well, we can label behaviors that we see that we know are wrong. Let's try not to label people. Let's care for the patient, but let's not lose sight of, like, we need to have a sense of empathy here and justice and inclusivity. And what kind of feedback have you had from some of these learning guides that you've put out there?
Well, the one that you're probably referring to mostly is the CPR racism guide, and there's an evaluation form. And I have developed a relationship with a PhD student who's First Nations at Windsor, Ontario. And she's actually taken the CPR racism guide and they've put it into their simulation within their curriculum and gathering data. But what I'm finding and hearing back from those who have responded is it makes a difference in terms of awareness that these are issues. And second of all, it gives them the opportunity to practice in advance, like with simulation, what they could do, what are possibilities. But most of all, the CPR racism guide for me, it's an advocacy framework, and it's about harmonizing relationships. It's about how do we, in those really stressful moments, find a way to communicate a need or something that feels very urgent, that is respectful to our colleagues, and of course, centered on the best outcomes for any patient who comes into our care. And that's why in the guide I talk about don't call someone racist. It's never helpful. It's about calling out the behavior, what's going on in terms of how can we get involved and how can we make a difference like as a team.
You have seen a number of places where Indigenous patients feel unsafe when they go into acute care, when they go into hospitals. And I'm thinking about some of the key cultural components that, I mean, beyond some of the trauma that a person might already carry, some of the cultural components that non-Indigenous people just wouldn't consider about going into a hospital setting.
Yes, well, there's many cultural considerations, and I'm just probably going to share a couple. But this history of mistrust and this history of fear of hospital settings is really rooted in colonization. It's rooted in residential schools, the role that healthcare providers played, but also in Indian hospitals. So there's history that contributes to the mistrust that is commonly one of the greatest barriers. But I would say when you're looking at cultural differences, the two I'd mentioned, probably one is hair, is the significance of hair, and in how that is very different in a First Nation culture versus other people. So the hair is very significant, and we talk about unfortunate policies going back to residential schools when they cut everyone's hair, they cut the braids off. Like this is not a new practice. This was part of the assimilation with the introduction to residential school. So it has deep trauma roots when you look at cutting hair of Indigenous peoples. And then when this practice is continued, then it's actually re-traumatizing, bringing up this history and then further traumatizing. And that's why I always come from a perspective of education and awareness. If we know the history that has happened, then we're in a better position not to repeat those harms. And that's why it's critical that all Canadians really learn about this history so that we're not perpetuating in any way these types of colonial harms that have happened.
I think last year the Saskatchewan Health Authority did pass a policy on what should happen in terms of if hair has to be shaved or cut. What do you make of that policy? Like, has the right thing happened here? And what is like, because I can't imagine somebody walking into hospital and having their braids cut now, but I can see people, oh, well, we'll just shave this, we'll just shave that without even checking. What should be happening and why?
Well, I fully support what SHA has done, and I really feel positive about this move in the sense that it's a new consenting process. So there are steps that have to be adhered to before someone's hair is cut. And that's to mitigate this type of behavior. The challenge is it wasn't just happening in hospitals, it was happening in daycares where little people, were coming home 4 or 5 years old and their braid is cut. It was happening in different environments. And there were some that were publicly profiled in Saskatchewan, which led to them actually addressing it. And so I think it's such a strong step acknowledging the harm that's been done, but more importantly, taking action to redress and to ensure that this doesn't happen again.
Well, as a white person, I wouldn't have known the difference between if I put the hair that I've had to cut off with consent in a Ziploc versus in paper. What's the difference?
It's supposed to be about being respectful. When we cut hair, we don't put it in the garbage. We take care of our hair differently. And so even there are those sometimes when they visit a hairdresser that they don't have their hair put into a garbage. So it's just a different way of the way we treat hair. We look at it as connection to our spirituality and a connection to spirit world. And so there's certain processes and protocol of how we treat hair, even who touches our hair, and once it's cut, how it's treated. So,
Well, and you said that wasn't the only cultural component. Are there any other examples of things that are just a little different for Indigenous patients when they come into that hospital setting?
well, I'll mention another one. It's about visitation. And I know that's always a challenge because as nurses and healthcare providers, it's, you have to do your monitoring and checks and spend time with patients. And there's procedures and tests where you do need to have that one-to-one time. But one thing I've noticed through the years is, say, if someone's in ICU and they've just undergone, it could be surgery, it could be an MBA, any number of things. Often the nurses will encourage the families and really work towards getting them to go home. They'll say they're unconscious, they're not going to wake up for, X amount of time, X amount of hours. And one of the beliefs that I was raised with is that when we have surgery or unconscious, that family has to be close as part of holding the spirit. And that concept is probably pretty foreign from a Western perspective and certainly from a medical perspective. But it's a belief that I grew up with and have practiced. So when we've had someone who's been in ICU, for example, my mother had open heart surgery, there was one of us always in that room. And I think that there's just not that understanding that many First Nation peoples have this connection, a spiritual connection, which is very different from religion and very different from how many others may see themselves in the world.
So how do we put this into practice? Like, how do we get this out to more people?
Well, the CRNS, which is the College of Registered Nurses of Saskatchewan, has been a wonderful partnership with me throughout this chair. And what they've done is they've mailed this out to every nurse, 14,000 nurses in Saskatchewan. So they've all received a copy of it. And it's also been included in the new anti-racism guide, the CPR racism guide. And it's also been a part of national guidelines for both CAUSE and other organizations, Canadian Federation of Nurses. So it is out there. It's being put into curriculum. And it's just really like a stop check. If I'm looking and I'm seeing something that doesn't feel right or doesn't seem right, how do I begin to address it? And that's what the CPR Racism Guide is about. Because if we look at the current health disparities, it's unacceptable. There have been some changes and some movements, but we still have First Nation communities who don't have safe drinking water. We have many that don't have appropriate housing, or the housing that they have doesn't meet code for egress, doesn't meet code for other things. So when we look at the development of respiratory conditions, we can see the relationship that has to housing. So it's really about drawing attention, creating awareness, but also harmonizing relationships. How can people work together? And how can we do this in a good way? Because ultimately, I believe we all have the same goal. We want to use science and best practices for everyone to have the best health outcomes.
If you could go back and talk to, your 18 or 19-year-old self who is, okay, I'm going to take this 2-year nursing diploma at Kelsey. Is there anything you'd share with her?
It's been a journey, and none of us knows what life holds. And I was fortunate. My mother was a fluent Cree speaker to be brought up with my spirituality and the belief in the Creator. And I've always prayed. I never knew where my life would end up or how it would look, but I prayed and I had faith. I just had this, I'll put it out there, say what I want to do, and had trust that the doors would open. And that's exactly what's happened, is my life has evolved in a way that each path I've been on has contributed to where I am now and how I see the world. So, no, there would be nothing about change your path or anything. It was just keep trusting as you are.
Thank you so much for just sharing your time with us on this podcast and for being who you are and getting all of this out into the world. We really appreciate it.
You're welcome. And there's a publication. If you just Google my name, CPR Racism, of course, there's a publication that shows you how to work it. And there's a video that I mentioned that the College of Registered Nurses of Saskatchewan has on their website. It's also on the Professional Practice Group website under Nursing and Reconciliation. That goes into much more depth of how to use this and what type of, approaches to questioning current care that is currently being delivered in a way that promotes harmony.
I'm going to go and make sure that we've got links to those in our show notes. So if somebody's just listening, you can go and click on the show and you can, we'll make sure those links actually make it into the podcast.
And the evaluation form with it.
Yes, let Holly know how she's doing.
Yes, and what else do people need? How could I improve the CPR Racism Guide? What's missing? And what else can I do to facilitate that gap being addressed?
Dr. Holly Graham is a Cree registered nurse and registered doctoral psychologist. She's a professor in the Department of Psychiatry at the University of Saskatchewan's College of Medicine. Holly Graham's also a member of the Thunderchild First Nation, and she holds an Indigenous research chair in nursing. I'll put a link to Holly's professional practice group for Indigenous nurses on our show notes, and you'll also find links to a few other things she mentioned, including that CPR racism guide. Researchers Under the Scope is a presentation of the Office of the Vice Deans of Research at the University of Saskatchewan's College of Medicine. We record and produce this podcast on Treaty 6 territory. We pay our respect to the First Nations and Métis ancestors of this place. We reaffirm our relationship with one another. We do want to make healthcare better for everyone. And this is the part where I'd like to say thanks for listening to the show and for caring about science and research. I'm your host, Jen Cannell. Thank you for listening to Researchers Under the Scope.